Welcome to the Moxie OT podcast, where we invite occupational therapy practitioners, consumers, and friends of OT to talk about evidence-based practice. Today we'll be talking to Monika Robinson, occupational therapist, faculty member at Midwestern University, and owner of Living Fully at Home, about integrating occupational therapy into home-based primary care. While primary care may not always be the first place we think about implementing occupational therapy interventions, when it comes to health, wellness, and preventative care, it's the perfect place to be. Let's meet Monika. Today on the Moxie OT podcast, we'll be talking with Monika Robinson about integrating occupational therapy into home-based primary care. Monika is an OT and on the faculty at Midwestern University. She's also the owner of Living Fully at Home, a company that provides home assessments and home modification recommendations. Monika and I work together at the university. Thanks so much for joining us here today on the Moxie OT podcast.
Oh, I'm so pleased to be able to do this because I'm really passionate about this topic and I really hope to spread the word so more OTs can get involved. So thank you for having me.
I'm so excited that you're here, Monika. I first learned about OT and primary care when I was studying for my OTD, and I became really excited about its possibilities. So when I learned that you were also excited about this topic, and we actually have a lot of shared interests, including sometimes letting me cry in your office. But can you tell us a little bit more about your background and how you became interested in OT and home-based primary care?
You know, I was actually walking the dog yesterday and I was thinking about my trajectory as an OT, believe it or not. And I don't know if the podcast elicited this, but I was a new grad and I remember going back to our church and there was a vicar there and thinking about some of the members of that congregation where I grew up that needed some help. And I remember going out there literally with a reacher, a long-handled shoehorn, and whatever simple adaptive devices, and going out and doing these visits. And it was just out of the blue, you know, just kind of out of pro bono volunteer. And so I probably should have recognized right there and then, even as a new grad, that home health and being in the home was really where my heart was at. But I didn't enter home health practice until decades later. I followed a pretty traditional trajectory of doing an acute care setting, which was great to expose me to all the different conditions and at least being familiar with the medical model in terms of service delivery. And then got involved in a community-based practice as a non-for-profit. And that kind of whet my appetite again because it was a very family-centered approach, very community-based. Went back to school, really became knowledgeable about value-based care just before the ACA rolled out, you know, when Harvard was still looking at it, Harvard University, that is. I think that's the earliest recollection I have of it. But as these value-based models were coming out and there was more emphasis on the community, serendipitously, I was about going back to school and home health was really the natural fit for me, trying to juggle school and going back and having to have an income. So there I was in home health and why wasn't I here sooner and be able to do this again? And so living in home health OT, to me, it's like the reality show of OT, right? It's where the rubber hits the road and you're actually implementing the practice within the real context.
So I love that. And I do think that there's such a role for OT and home health. And we're living in a world right now, we're recording this in December 2020, the last day of December in 2020. Where we really need to advocate for OT's role in home health. But I think I have a question or a clarification, because when we talk about home-based primary care, are we talking about physicians or other primary care providers who are coming into the home?
Yeah, so I'm glad you clarified that because home health practice, as far as when we think about it, traditionally offered through a hospital-based program or even a private practice, is an older adult population, and it's usually covered by Medicare services or private insurance. Home-based primary care is not episodic. And to coin a phrase from Carol Siebert, who I'll refer to again, who does a lot of primary care within the home, delivering home-based OT services, refers to it as being longitudinal. So it's the idea that you're actually creating a relationship with an individual over a long term and providing services that really focus on a lifestyle. So similar to just like you would see your regular doctor, you have appointments that you see them for wellness visits, or when you go and have a specific problem, that would be the same way you would do that as an OT. So let's take it from the perspective of primary care in the clinic, where OTs are found in some of the primary care clinics, outpatient clinics. A lot of those same service delivery models, but you're actually being able to deliver those services in the home. So it is different. It isn't home health where you're going in for an acute specific onset of a medical problem and then leave the home. It's much more long-term based. And I would go to a model such as the VA, the Veterans Administration, where they've delivered something like this. So if you talk to a physician and you said home-based primary care, of course, they would say that's a physician. But even within that term now, home-based primary care is seen as a team. And so it's beyond just the physician. And even in the outpatient models, they recognize the value of an interdisciplinary team collaboration. So I think it's a natural extension to think about that. If it's going to be home-based in the home, delivering primary care services, it should be a team-based approach in the home as well.
I'm so excited by this concept. I think it has so many great opportunities. I have a couple of maybe questions or clarifications. I just want to kind of help me wrap my head around this. So, what is when you talked about sort of the traditional home health model, you talked about an older adult that maybe had recently been ill or had a surgery or something. What is the kind of typical client that might benefit from home-based primary care from an OT?
Well, I think that typical client could still be an older adult that is living in the community and doesn't necessarily have to be homebound, right? So you're providing the service for an individual because the service is a better provision for that person based on their needs. There are demonstration projects from Medicare that have instituted a lot of these different types of models that are largely based off of the VA administration's model. And so with the VA, you have a wide range of people and age groups there as well. Any veteran who served in the service is eligible for these services. I believe there may be some stipulations in terms of if they have to be homebound or if there's special conditions. I haven't worked in that environment, so I don't know exactly the specifics. But I could see primary care services being delivered to the medically fragile child who doesn't have an opportunity to get out of the house very easily if they're on a respirator, or even the EI services for those children that might be a little bit more medically compromised, early on. EI is essentially primary care in the home. It's a long-term relationship with an individual, looking at those foundational skills that they have to implement to kind of be preventative of any secondary conditions that can be associated with whatever developmental milestones are being challenged. So I think I've never thought of it that way, but I think it could almost be construed that way as well.
Yeah, I think so. I think EI is a great example. Lots of those kids, I'm losing my earbuds. EI is a great example. Lots of those kids do have medical challenges, and lots of those kids are not homebound, but do have, occupational challenges that they benefit from that long-term longitudinal care. And I can really see how EI is kind of a great example of what home-based primary care can be. I'm also thinking about sort of the typical example that I think about when I think about OT and primary care, and doctor's office of those folks with like a chronic condition like diabetes, and how OT can really help with the problem solving of like, oh, you're chronically forgetting your medication. How can we set an alarm? Can we set it out where you'll remember it? What are those very typical strategies that OT thinks to help someone implement that, other professionals that's not their job to think about. If somebody's actually coming in your home and looking at your context and thinking of, helping you problem solve, and then coming back next week to check in to see how that went. I mean, what a great opportunity.
Well, I have an example where I followed a home-based primary care physician here in the Chicagoland area, and I was fortunate enough to allow me to do that, just so I could see what would it realistically look like. Would there be a lot of patients within that physician's?
I'm sorry. We had a technical error. Hold, please. Apologies.
This is our first technical error, Monika.
Oh my gosh.
Sorry you had to be here for it.
No worries.
Hold on to that, because I was really excited. You had an example from when you were working.
Yeah. I'm gonna hold you in suspense.
I apologize. We need to go back to where Sarah was talking about chronically forgetting, patients who are chronically forgetting their medication.
Okay.
I appreciate this. Sorry.
That's okay.
Are you okay, Bri? Everything's okay?
Yeah, I'm just flustered. I don't know why things stopped recording. It's frustrating.
It's 2020 to the very end.
That's right.
Okay. However you want to get into it, I can just cut back. But do you know where I'm talking about?
Yeah,
you know where you're going?
I got you.
Thank you for your consideration and patience. Take it
problem.
away whenever you're ready.
All right. So I see so many great opportunities and examples for this model. I'm thinking about the model of occupational therapy traditionally in primary care in the doctor's office. And when we think about those chronically ill, is that even the right term?
Yeah, I would go with that.
I don't know why suddenly that didn't sound right. Okay. Starting over again, Brian. So I can think of so many great examples and opportunities for this model. I'm thinking about the example I commonly use when I think about OT in traditional primary care in a doctor's office with those folks with chronic illnesses like diabetes, and how OT can really come in and help people problem solve, like, oh, you're chronically forgetting your medication. Can we set a reminder? Can we put it out where you'll remember it? What are these common strategies that OTs make recommendations for that other professionals just don't think about? It's not their job to strategize. But if somebody can come into your home and problem solve with you through those strategies in your own context, they can see, oh, you're forgetting your medication because your counter is covered with stuff.
Yeah, no, absolutely. So, maybe the best way to explain this, well, first off, just a little bit of background history too. Home-based primary care for physicians is booming as well. I mean, the doctor that would visit you at your home when the medical model came about kind of took that all to the institutions because that was maybe considered better care. But now things are beginning to migrate back into the community, into the home, because there's a greater recognition of the significance of social determinants of health. And so community-based practices and home-based practices are definitely acknowledged to provide more value to the care. But here's an example where I would provide for you the difference and where the value of OT is for a physician providing care in the home. I followed a physician one day who does this full-time in the Chicagoland area, and with the idea being that I wanted to see what's the reality of this situation. Does OT really have something to offer? Could I see from the caseload from one day where OT would be able to contribute something valuable? And the second client that we came to was a young man, had a significant amount of lymphedema, which that's not really what the primary focus was. There were some other comorbidities that they were dealing with. But this was a young man. I mean, this was somebody in their 30s who was independent in ambulation. So, I mean, they could have technically probably gotten out to get their care. But he also had some other psychological overlays like agoraphobia going on with this. And so even during that short time of where the physician was doing his intake and taking the vitals with the certified nurse assistant, medical assistant, I saw the environment in his home and how difficult it was and how his positioning was contributing more to the edema in his legs. And he wasn't getting out and doing the routines, as you mentioned, in terms of taking the medication in his day because he had such significant depression was affecting his ability to follow through on managing some of his other chronic illnesses. So to me, right there and then, those were issues that I saw that the physician was not addressing, which is how is that home fitting that person? And how is that contributing to his lymphedema, which fatigues him and doesn't further inhibits him in being able to do more activity. And so I shared those findings with the physician and he totally agreed. And that's not on their radar. I mean, they're in there to serve a different purpose. And so that's a perfect example of OT coming in there. And there are so many things on a prevention level, whether we talk primary, secondary, or tertiary, that could have been applied to this specific case, where tertiary, we would have talked about treating his lymphedema. Secondary, we might have talked about getting involved in some other activities to prevent further deconditioning or further onset of other conditions by having him being more engaged in meaningful occupations, which was clear he was not. He was pretty much in his bedroom watching TV in a really sedentary position, not doing a lot. And then primary prevention, just getting him involved in what interests him and exploring that, doing an occupational profile and seeing what are his interests, you know, doing a Canadian occupational performance measure to see how satisfied was he with this, you know. And I know from that brief interaction that there was a lot that could have been done in terms of an OT coming in there.
Yeah, and it's such a great example of just everything that your OTI see that we don't even realize that we're seeing until kind of we realize another professional's not seeing them. But having that opportunity to see somebody's home in their context versus even being in primary care, where it's such a great opportunity to be on the more preventative side of things, but to get to go into somebody's home and really just be that much more effective. I think as OTs, we talk so much about PEO and context and all of these things, but so rarely do we really feel like we're living that out. And this is such a great opportunity.
Yeah, it's very clear that physicians, when they are in the home, at least the few conversations that I've had with those that are home-based and provide primary care in the home, they recognize and fully acknowledge the social environment and all the factors that contribute to that person's health and how important that is. But they really don't have effective means in their training to deal with that social environment. So the value of a social worker has come into play in a lot of practices and a lot of physician practices. But I think when you think about something like what I just gave you that example, where there was even physical manifestations where we could have intervened and talked a little bit more about that psychosocial aspect, that really would have helped further as well. So a social worker could have, in a traditional sense, maybe link this individual up with some community services, but I think the active engagement in something meaningful and really getting to their self-efficacy is really important. And I think that's something we could bring in.
I think that's so true. And, I think that was one of my questions on my sheet, but you already answered it. It was like, what is OT's role versus social work or nursing or some of the other folks that, a primary care physician might already have on their team. And actually thinking about that engagement level is just, that's where our bread and butter is. And we need to really recognize our worth and our value and what we bring to the team.
Yeah, I think really highlighting when I did a webinar recently for a group of primary care home physicians, I really emphasize that our unique contribution is understanding that person, environment, fit, but also using occupation as the means for treatment, right? As the means to the end. So if the difference between a nurse practitioner who's going to go in there and everyone's being holistic, we're not the only ones that approach a client holistically. It's the difference of asking them about their symptom management with medications and what their lifestyle is about versus us asking them, what are you doing and how are you actually engaging in this activity that's going to promote that healthier lifestyle for you, if we're talking about someone incorporating self-management strategies that are being recommended by the nurse practitioner.
Yeah, I love that. I think I'm very excited by this. Maybe I need to go out and get a new job. I don't know. But I think that comes to my next question, which is the big elephant in the room, because I'm sure every OT listening to this agrees with us, is very excited about this, understands the importance of prevention. But can we get paid for this? Are there any service payers or insurance providers that are paying for OT primary care?
So if we think about the traditional route, if it was, say, an older population, and we're talking about the chronic comorbidities that individuals have that would require that maybe or benefit from that long-term engagement, Medicare Part B is the first one that you would go to, right? And so that's possible, but again, they view that as being episodic, right?
Mm-hmm.
The only way I think we can actually get in is if we actually show our value by how we can change the quality measurements or the metrics that are utilized by existing Independence at Home program demonstrations as an example, or the Hospital at Home demonstration project. These are two projects that were started as a means to reduce the institutionalized care that individuals required. So the Independence at Home measure was a result of a demonstration project through the Center of Medicare Innovative Project, I don't remember the exact acronym, that started a number of years ago and has now been extended because it's been so successful. I mean, in the first 2 years, they had 15,000 beneficiaries involved in there, and they saved $2.8 million in terms of hospitalization costs. So the thing about it is, Independence at Home, how that program works is people can receive primary care services in the home, but guess what? They have to be eligible by having 2 functional deficits, and there's no OT involved.
Oh.
So the requirement for eligibility is, besides being a Medicare recipient, is that they have to have a chronic condition, I believe, and 2 functional limitations. And there's no OT in this program.
I won't say what I think that is, but it's heartbreaking to hear.
Well, and we as a profession, if we go and we look at our efficacy of our services and approach, say, a private practice home-based physicians group, the conversation I would have with them is, I'm going to try and make a difference at what your quality metrics are going to look like. And they have 6 quality metrics that they have to, that they can choose from. And I think they have 3 that they have to report on. I may not be entirely accurate on all these facts, but it's something along those lines. One is patient preferences. So we have tools like the Canadian Occupational Performance Measure that is totally about patient preferences. Like, what do they want to be able to do? It may be referring to the medical care. I'm really not sure what that measurement itself looks at, but we can certainly support patient preferences, whatever that scope is, even if it's in the choice of medical care. The other is hospital readmissions. Well, we know we're effective at reducing hospital readmissions. That study by Rogers that was done a few years ago that showed the highest spend on OT was the most effective in terms of reducing readmissions for congestive heart failure, myocardial infarcts. That's already been out there. Another quality metric that I would talk to another physician's practice about is hospital admissions for ambulatory care sensitive conditions. And so we as OTs, with incorporating self-management strategies, being able to look at medication management, being able to look at functional cognition, could probably help prevent some aversive effects from even being able to manage their medications. we know congestive heart failure and diabetes are accompanied with cognitive decline, but a medical model doesn't address that. And so we could probably have some of these hospital admissions for ambulatory care sensitive conditions be avoided, as well as emergency department visits, which is another quality metric that's measured on. So I mean, those are specific quality measures that are currently being addressed through this Independence at Home project. And so I think as a profession, if we were to approach this demonstration project and say, where can we help you improve these quality metrics, then we become one of those providers that gets paid as part of this demonstration project. So it's really making the difference about how we can show we can change outcomes. It's essential that we show we can change outcomes.
And we know we can. We have the evidence to show it, but we need to continue to build that body of evidence and make our way into these projects, like you were saying, so that we're at the table when these projects are being developed.
Well, and we're kind of in some respects at the periphery, because we talk about all of these things that we do in terms of interventions, but we don't call it primary care in the home. So when we talk about fall risk reduction, we talk about home modifications, we talk about improving cognition, we talk about medication management, but the literature, when we're producing it, doesn't call it primary care in the home. And so if you even try and look up the literature, it's really difficult to extrapolate and say, well, here's how we can be effective. So I think even what we're doing, what we're calling it, needs to be different. You know, we need to be clear about what it is that we're offering. Maybe there needs to be some essential components that have to be defined.
Right. Maybe we need to better define what is our role here and how, you know, and just essentially create a few solid studies that will demonstrate how we can be effective in home-based primary care.
Yeah.
So I think you have built a really strong case if an OT wanted to go to a MD or physician who was providing home-based primary care and to maybe sell themselves to the practice. And so if an OT was getting started in this space, you talked about the Canadian Occupational Performance Measure, and it's one of my favorite tools, and it comes up a lot on this podcast, really. Are there other assessments or other tools that you would recommend that OTs explore?
Yeah. I would, you know, and I'm going to give you a framework too, in terms of what the medical model what I became exposed to and actually learned about when I attended a home care medicine conference on primary care, were the 5 M's. And so they call it the geriatric 5 M's of what matters. So the geriatric 5 M's of what matters is mind, mobility, medication, matters most, and multi-complexity. So even if we approached a physician's practice and we said, specific to each of those categories, what are some standardized assessment tools that would tell you we made a difference in the person's mind, or we made a difference in the person's mobility, or we were able to show that we did address what mattered most to them, or that we were effective in helping them manage their multi-complexity. Some specific tools that I come up with are, when I think of the mind, I think of cognitive performance, right?
Right.
So the skills to care model, which, you know, is as the assessment treatment approach. It was published by Gitlin. It talks about cognitive assessments, helping the older adult with dementia, because dementia is a very problematic area for physicians to manage, both pharmaceutically and also behaviorally, you know, in terms of how that affects the caregivers. But I would also think about the PASS tool, performance assessment of self-care skills. There's a wealth of specific ecologically valid assessments in there that could address a lot of these different M's that I just talked about. I think about the
very robust tool with a lot of, you can choose which components you want to use according to what you want to assess. So
right, so you could break that up between all of those M's, between the mind, mobility. There's another one that it comes out of WashU called Home RX, and it's a medication management assessment tool. So when you think about medication, obviously that's a great assessment tool to look at specifically. And there are other components that you could look at too, like the executive function performance tool, also from WashU. The IHOPE, which is the in-home occupational performance evaluation, also from WashU. Sound like I'm doing a little promo for WashU, but they are very centered on community and home-based services. So that is a great assessment tool to look at the performance, the occupational performance of someone in their home. And there's actually one that they have for the caregiver as well called iHope Assist. So it assesses the caregiver's ability to take care of someone in that home environment. Another assessment tool that I've used personally is the Safer Home Assessment Tool. It has a nice quantifiable scale that you could use. So when we look at medication management, we've offered a couple assessment tools to help manage medications, assess someone's ability to take medications. When we looked at mobility, we're looking at home assessments in terms of occupational performance within the home. When we look at the mind, we think of all the functional cognitive assessment tools that we have, and functional cognition is that key phrase that we're really looking for, right? We're not looking at a MOCA. We're looking at an ecologically valid assessment tool that looks at what a person's occupational performance is like.
Yeah, I think those are great examples, Monica. I love that they're all, like you said, ecologically valid, occupation-based, and many of them are free and available, like you said, on the WashU website or other university websites, which is really helpful to an OT who's maybe just getting started or having to prove their worth, and it might be hard to justify a really expensive assessment. So well-proven assessments, but also affordable. So that's always really helpful as well.
I think another way to get our foot in the door is to really profile the significance of OT in a model like the Capable program, which is the program that was instituted it was also an innovative project program with the principal investigator being Dr. Sarah Santon, a nurse practitioner out of Johns Hopkins. And she's actually now has shared with me that they've aligned themselves with one of the major primary care home providers. So there's a great opportunity for OT to really profile what they're able to do. And they're reported as being part of a home-based primary care model.
Yeah, I think the Capable program, I'll provide a link to some more information on it on our website. It's such a really great program that I think it's a limited number of visits, but they partner with a handyman and a nurse and, do some very simple adaptations and have made huge change, saved a lot of money for Medicare, and have had some really awesome outcomes.
Well, I'd really like to highlight that, and this is where home-based primary care, the Independence at Home demonstration project, I believe largely sprang from, was the experiences of the VA. And so they have the home-based primary care team, which has a psychologist or a behavioral medicine person of some sort. I think they have a social worker, they have PT, OT, speech, and the physician and a nurse. I'm not entirely clear on if all of those are there, but it is a huge multidisciplinary team, and they follow that individual, so they know that person. And they've shown dramatic results over the years, and so they've oftentimes been cited kind of as the framework for home-based primary care, especially when you're looking at an interdisciplinary approach.
That sounds, that's a model that I'm going to need to explore more of. I'm really excited to look at it, and I'll seek some resources from you and make sure I provide those on the website as well.
Yeah, OT Practice had OT published, I can't remember the month, but there is an article about their experiences in OT providing home-based primary care through the VA model.
That's so cool. The VA, they have a little more opportunity to play with things, and they a lot of great innovation comes out of the VA. Is there an OT or a model that been successful in implementing primary care? I guess we talked about the VA, but I think you had some other examples you wanted to share with us.
Yeah, so in the southern region, there's an OT by the name Carol Siebert, who's well known in the world of home health and probably other arenas that I'm just not familiar. But she provides home-based primary care through, I think it's a federally qualified medical center, health center, a FQHC, or a patient-centered medical home, one of the two. And so it's encompassed in the dollars, the managed care that they receive, I believe, through their Medicaid organization, reimburser. So it's kind of enveloped in there. And so she provides services through that model. So I think that's another way to approach it, is look at your patient-centered medical homes. And as much as we've been talking about primary care in the clinic, maybe it could be a hybrid approach where you allow yourself to be able to provide primary care services in both settings. Make it so that it's flexible enough that you can go into a person's home, but then also see them in the clinic. That could be a natural extension.
Yeah, go ahead. Sorry.
Yeah, no, so that's one model. And the other is that the accountable care organizations are looking to provide more home-based services. And I think especially in light of the pandemic, you know, people realize we can rely on technology now. It's improved to be able to have more venues of how to deliver the service. So there's another opportunity there as well, is to make yourself an extension of one of those services through the accountable care organizations. So value-based care can function in a number of different ways. It could be where the organization decides to assume some of the risk. You know, if they don't meet their quality metrics, then they have a penalty. But if OT is encompassed in part of those services and they show that those metrics really improve, then they also have where they can gain. So they have shared savings programs too, where Medicare and the organization, I believe, share the savings of whatever has been saved through the services that they provided. So I think that's why we really have to think as OTs about value-based care, because we have to understand how these metrics affect payment and how we can be part of that payment model.
Absolutely. And I think, you know, through the Rogers study and other studies where we've really demonstrated that we are the ones that are saving money, we need to be knocking on doors and letting people know that, and then, you know, take our seat at the table.
For sure. I think we really need to think more about that end outcome. And I think there is a greater awareness amongst the practitioners for that. I'm hoping at least we try and do it with our students, right?
That's right. They probably get tired of hearing us talk about it, but that's okay. Repetition is good, right?
Yeah.
So, Monika, at the Moxie OT podcast, we always want to make sure we provide an opportunity for our listeners to increase their Moxie. And we've talked about a lot of resources here on this episode, but are there any last resources that you want to provide for our listeners?
Well, it's also a plug to market ourselves. So by accessing these resources, I'm going to say make it obvious that you're an OT if you access these resources. So one that I would tell you about is the Home Care Centered Institute, abbreviated HCCI. And they are a non-for-profit that exists to educate physicians about home care practices, because they experience a significant gap in being able to recruit physicians to provide primary care in the home. And so I think we need to be able to access those resources to show the efficacy of primary care. And if they want to be exposed to the different models and who actually the movers and shakers are who've developed these demonstration projects, they're oftentimes involved in this organization. So I think that's a great way to collaborate, not only to find out information about home-based primary care, but also start networking. I would visit that site. Another one is being familiar with the National Home-Based Primary Care and Palliative Care Data Registry. And what this is it's a repository of the outcomes that the sites it may require a membership to get in there, but I think it's important that we're aware of what their metrics are that they're being assessed by. You know, Collaborating with any palliative care physician is another great opportunity. Any palliative care organization, like the national organization. There's a national organization called the American Academy of Home Care Medicine, abbreviated AAHCM, and that's another organization where they have an annual conference. The Capable program was profiled last year as a keynote presentation, and they are looking for more interdisciplinary collaboration there.
Well, those are so many great resources. I've got a lot of homework to do to make sure our website is updated after this episode. I think that this episode should really fire everyone up to get involved in primary care. And I just thank you so much for your time today.
Oh, my pleasure. It was fun, Sarah. Thank you.
Thanks for joining us for this inspiring conversation with Monika Robinson on integrating occupational therapy into home-based primary care. For those of us working as OTs in the U.S., AOTA provides official documents which describe, provide examples, or make recommendations regarding education and practice in occupational therapy. AOTA's position paper, Role of Occupational Therapy in Primary Care, is a helpful tool for those interested in exploring OT in a primary care setting. As Monika discussed, it is important to know OT's efficacy. Rogers et al. Found that occupational therapy was the only spending category with a statistically significant association with lower readmission rates. With the ACA's current focus on decreased hospital admissions, this is an important finding for OTs to bring to the table. One of the models Monika discussed was the hospital at home care model. This model, currently being implemented by VA hospitals and several other health systems, reduces spending costs by bringing health care to clients in their home. The Independence at Home demonstration project works with medical practices to provide primary care services in the homes of those with chronic conditions. One of my favorite tools Monika described is the Performance Assessment of Self-Care Skills, or PASS, which is a performance-based and client-centered assessment tool. It provides the OT with the ability to assess a number of ADLs and IADLs. Another one of my favorites is the Executive Function Performance Test, which examines executive function through 4 common IADLs. An important program to know about is the Capable program, which enables seniors to remain at home by providing nursing, OT, and handyman services in their home. We'll have links to all of these resources on our website. If you want to be a part of the conversation, leave us your email address at moxieot.com. We're on all of your favorite social media channels as well. The Moxie OT podcast was recorded in our home in the Avondale neighborhood of Chicago. This episode was produced by Brian Zira. Our intro music is courtesy of 13 Tacos Studio. Technical assistance was provided by our dog Grody. Thanks for joining us. We'll see you next time. Give up your time on this holiday.
We'll send it out to the universe with good thoughts of prosperity and helpfulness to whoever it helps, right?
Yes, it was good. So we're